Okay to begin?
Yes.
All right. Well, thank you all for tuning in this morning, or dialing up, or logging in, or whatever. It's a privilege for me to be here as well. And when David called me to do this, I said, yeah, I've been doing electrocochleography. I look back on it now since the 1980s or so. I was a junior high student when I started. Just kidding, I wish that were the case. And so what I thought I would do today is give you a brief overview of what the technique is, what we primarily use it for in the clinic, and then focus pretty specifically on recording parameters using the Endoacoustics Eclipse unit. And we have two of those units currently functioning in our laboratory now that I use for clinical situations. I use it to teach our students how to do an evoked potentials, and we find it a very useful unit, and especially the new software with the event protocol has been very helpful for us for the several studies we have going on and what is now becoming a very popular evoked potential test. But we'll focus on electrocochleography today, as I'm sure most of you know, is a technique for recording the stimulus-related potentials of the cochlea and auditory nerve. Unlike anatomical descriptive names like auditory brainstem response or P300, etc., ECochG is a technique for recording components that are labeled other things. And if we take a look at the family of auditory evoked potentials kind of laid out in one broad time frame, which of course we never see it like this when we're doing recordings, but this is simplified for descriptive purposes. ECochG really involves recording the components that represent the shortest of the short latency responses or the earliest of the early latency responses, and those are the responses that occur within a time frame of anywhere from 1.5 to about 5 milliseconds following the onset of a stimulus. The components of interest generally include the cochlear microphonic, the cochlear summating potential, and the compound or whole nerve action potential of cranial nerve 8 or auditory nerve. This slide here is a really old one that I think L. Coates published in the early 1980s that show the response, or an electrocochleogram, if you will, to Eclipse stimulus. And some of you might have noticed from the previous slide that here the peaks are going up, here the peaks are going down. I will tell you, if you don't already know, how to alter the polarity of the response depending on which way you like to see the peaks. Some people like to see them going up, some people like to see them going down. Personally, I like to see ABR peaks displayed as upward deflections and electrocochleogram displayed as downward, but that's just a simple matter of reversing the inputs to the preamplifiers as long as you know you've done that and in which directions the peak should be going. But let's get back to this slide here. These are responses to rarefaction and condensation. Clicks overlapped together, and what you get in response to rarefaction are components of the electrocochleogram that are either phase locked to the stimulus, like the cochlear microphonic, or are independent of stimulus phase, like the summating potential and the whole nerve action potential. So if you do responses to rarefaction and condensation, you can either add those together to cancel out the phase locked response, because it's 180 degrees, and that would be the cochlear microphonic, to display this small little shoulder preceding the summating potential preceding the negative deflection of N1 of the auditory nerve response. If for whatever reason you want to study the cochlear microphonic, which has been the case, for example, in recently regarding the diagnosis of auditory neuropathy or auditory neuropathy spectrum disorder or whatever we're calling that these days, then you could simply subtract the responses, and that enhances the cochlear microphonic. Today we'll primarily talk about the SP and the AP because the primary focus is how we're using those components to help make the diagnosis of Meniere's disease or endolymphatic hydrops more sensitive and specific. You have to spend a bit of time talking about how we record these components, and I will say now that virtually all of our recordings that I make in my clinic, in my lab, are using the tympanic membrane approach. There are 4 different electrodes shown here that all have been used and may be currently used to do electrocochleography. This is one we used to use. It's a homemade device patterned on an electrode that was described back in 1987 by Steve Stoller and Paul Stipulkowski. All it took was buying some wires, some elastic tubing, and getting a little cotton plug or foam plug and constructing it that way. And it still works really pretty good, and it's certainly an economical way to do it. But I would say for the last 4 or 5 years, we have been using the commercially available tympanic membrane electrode that was originally produced by Biologic, but now is, and I'll show you on the next slide, we're ordering them from Sanibel because they've taken over the manufacture of these things. I'm not aware of any other company that's manufacturing the commercially available TM electrode. This is a wick electrode described by Dave Lilly. I think some people continue to use this. It has to be saturated in saline and then placed into the ear canal. And it's a perfectly good electrode, but we found it kind of problematic at times that it tends to dry up and you have to keep saturating with saline. It can disturb the recording process. And then, of course, this is a very popular Electrode. I would say a lot of clinicians who are doing electrocochleography today in their clinics are using the Electrode and using the ear canal recording approach. We have abandoned that several years ago simply because it's not nearly as sensitive and stable as the recordings we get from the tympanic membrane. Now, nonetheless, if you cut this down a little bit and get it real close to the eardrum, you might get responses that are similar to the Electrode, I'm going to call that, but it's still not, again, in our experience, as good as the recording directly from the tympanic membrane itself. And of course, these are all extra tympanic recording approaches. And many countries in Europe, Japan, Australia, they still prefer the transtympanic approach, where you actually deaden the eardrum a bit, stick a needle through it to rest it on the promontory. That approach has not been well accepted in America for a variety of reasons, not the least of which is we like to get people to come back for second tests sometimes. And obviously, if that were the case, audiologists in particular wouldn't be able to do this approach without the assistance of a physician to place and remove the electrode, and that means a two-person team sometimes, and that usually isn't economically, if nothing else, feasible. So all of our recordings today, and all the ones I'm going to talk about, are done extra tympanically and primarily from the tympanic membrane. Again, here's a picture of the electrode that's commercially available. I think since you're all distributors, I'm assuming you probably know this better than I do. We are, by the way, still waiting for a shipment of electrodes that we ordered about a month ago, so I'm hoping they're coming soon because I'm running low. And I have a doc student who goes through these things like water, which is problematic, but hey. Obviously, what you need in addition to the electrode is a specialized cable that it attaches to. Excuse me. This cable allows you to not only plug in the active wire lead from the electrode into its appropriate jack in the preamplifier, but it also allows a common or a ground connection that actually grounds the shielding of the cable, which helps prevent some electromagnetic artifacts from jumping onto the electrode. And we found that a very useful feature to have with this cable. So again, it's a specialized cable. The cable, of course, can be used for a long time. The electrodes are designed to be disposable. The way I put the electrode in is simply we coat it with electrode gel, obviously to give it a good conductive medium, dip it in there. It doesn't have to have a whole lot of gel on it. And then I tell the patient that I'm going to run it along the ear canal very slowly until it bumps into the tympanic membrane. And I want them to tell me when they feel that. And most of them are very adept at doing that. They say, well, what does it feel like? And as soon as you get it, they say, oh, yeah, I feel it. And 99% of the time, it is not a painful experience. Every now and then, if we hit the annular ligament of the eardrum or the person is extremely sensitive ear canal, they may report some discomfort. But in the years I've been doing this, I've never had anybody say, this is so painful, I can't stand it, because it really is a fairly non-invasive, certainly non-invasive, but fairly painless approach. Once we have the electrode resting on the tympanic membrane, and I'm to a point now where I don't use an otoscope really other than to look into the ear beforehand to make sure I've got a clear path to the eardrum. But it's very difficult to try to use an otoscope and then insert the electrode and then verify its contact on the tympanic membrane because it's pretty big. And it's hard to see into that to see if it is touching. So my key is the patient acknowledges that it's touching the eardrum. I then use the EAR earplug tip here, and generally what I do is I cut them in half. That makes them a little smaller. I compress it, I stick it into the ear canal, it expands, and it actually holds the electrode in place and does a good job of it. And I normally use the smaller of the two diameters of the earplug to do that. The other end of the electrode, of course, is connected to the preamplifier, and once the patient acknowledges that they have contact with the TM, the other way I have of verifying that is I look at the raw EEG on the face of my evoked potential unit, and if that's relatively stable, non-cyclic, no peak clipping, etc., then chances are I've got good contact. And I don't measure, in fact, we have our impedance meter turned off. I don't measure impedance with this. It's going to be relatively high. It's a very small surface area. And when you measure impedance, you actually drive current through the electrodes. And I did that a few years ago, and the patients were feeling it. So I stopped doing that. And I've never really had any recourse or reason to be real concerned about impedance here. Recognize the fact that it's going to be high, but also recognize the fact that the electrode being more near-field in nature to the response generators in the cochlea will produce a signal that really is considerably higher than the noise floor, even in the face of a high impedance. Just a little bit about recording parameters. They're pretty much very similar to what you would do for an auditory brainstem response. Some differences here. Since I like to see my ECoG peaks going downward as negative deflections, then I use the tympanic membrane as my primary or non-inverting electrode site, and then our secondary or inverting site is the contralateral earlobe or mastoid. We've done a few studies that show that tends to give us bigger responses than using the ipsilateral earlobe, mastoid, or sometimes even the forehead. But either of those sites is okay as well. If I had to choose one not to do, I would say probably the ipsilateral side would give you the smaller responses based on the studies we've done. But the middle of the forehead or certainly the contralateral mastoid are good secondary sites. We use the the low forehead as the common connection or ground connection there. And again, when you do that, the polarity of the response, and I always have to remind my students that response polarity and stimulus polarity are two very different things. We're now talking about the polarity of the response, i.e. will peaks be displayed as upward or negative deflections. The polarity of the electrocochleogram when you use the tympanic membrane as your primary recording site will be negative or downward. For the ABR, if you're using the vertex or high forehead as the primary site, the peaks go up. And there's reasons for that, which if you want to know later on we can talk about, but just to move on. The signal averaging or analysis time, we can either use 5 seconds if we really want to look at a very focused 5 millisecond period, or you can extend it all the way out to 10 milliseconds or so. Generally don't get beyond that, or certainly less than that. Another important feature of the electrocochleogram recording is that we have to expand the filter bandpass to accommodate what is really kind of a quasi, at this stage, DC component. That's the summating potential. If you go much higher than that, you really will reduce visualization of the SP, and because it's a response to a very transient stimulus, it's not a pure DC response. So we can get away with recording it with an analog filter like this. The upper end is consistent with what our ABR upper end is because we want to see that whole nerve action potential component as well, and its fundamental frequency is about 1,000 hertz. You really don't need any more than 500 to 1,000 repetitions. I generally use 1,000, but sometimes just watching a response build in, we terminate the recordings well short of 1,000, but generally more than 500, 750 is a good number, and when the responses are building in beautifully, you don't need to go as much as 1,000 hertz, 1,000 times. Although we have used certainly tone bursts and tone pips and done a variety of stimuli in our research and even clinically, What I'm going to focus on today is just simply the use of the broadband click as a stimulus. And we generally deliver it at around 11 times per second. The beginning level is 90 dB, which is fairly loud, but we need it loud enough to evoke a well-defined summating potential component that precedes the action potential component. And since the SP is thought still to be at least representative of a distortion within the transduction system, we want that distortion to be as maximal as possible, which occurs when the stimulus is pretty loud. Okay. Here are very familiar, I think, at least representations, and these are from our lab, of an electrocochleogram evoked by a click stimulus. What we see here, this is the onset of the signal is, at this point, that's 0 time. And we see this little blip or shoulder that in a normal ear represents the SP, followed by the onset of the N1, in particular, of the whole nerve auditory, of the auditory nerve response. The term whole nerve versus compound action potential tends to be misused, I think, sometimes in literature. A whole nerve action potential basically leads one to believe the entire nerve is responding because it's a very broadband signal. In reality, the signal isn't all that broadband. It cuts off due to the filtering characteristics of the transducer, outer and middle ear, and so you're getting really a contribution from a relatively narrower portion of the basilar membrane than the entire membrane. So whole nerve is really kind of a misnomer. When you say compound action potential, that implies a more limited segment of the basilar membrane is excited, and generally when we record compound action potentials, a tonal stimulus is used, whereas a click evoked is generally referred to as whole nerve. Both are misnomers because even the compound action potential excites sidebands to the center frequency and gives you a response that's broader in spectrum than one might at least think by the labeling. So bottom line here, these are click evoked responses. Here's the AP component, here's the SP component. I pay attention to the SP component and this portion of the AP component. And 2 really represents kind of like wave 2 of the ABR. This is wave 1 of the ABR. And you'll find some variance in the literature among people who do this with regard to how they measure these components. You can measure them as absolute amplitudes from where they begin to where they end, etc. The SP in reality actually extends beyond into the AP, but the AP overshadows it. Nonetheless, this little blip represents a portion of the SP that's important, as you'll see in a bit. Then the AP starts, and if you measure the absolute amplitudes from the SP here and from the AP to where it begins to where N1 is, you'll get a certain set of norms respective to the way you measured it. On the other hand, some folks prefer to use a baseline for comparison and measure the amplitude of these components with respect to the baseline. That's not a bad way to do it, especially if you're doing transtympanic recordings where the baselines are very, very stable because the response is so big. But with extratympanic recording, and again, even on the tympanic membrane is considered extratympanic since it's outside the middle ear cavity, we have found the use of the absolute amplitudes measured this way to be a more stable way to do it because the baseline tends to not to be as stable and linear as this one is here. You all know that when we show tracings like this and say they're representative of the ones we get, that means they're probably some of the best we've ever seen in the 10 years or 15 years we've been doing it. But we all do that. Clinical applications, briefly. Intraoperative monitoring, inner ear, we're not really focused on that today. We were among the first to report how you can use a combined ECoG ABR approach. This is back in the late 80s to enhance wave 1 in the presence of hearing loss so that you can at least obtain 1-5 interwave intervals when conventional ABR recordings and hearing loss prevent good visualization of the early components. Again, mentioned before that ECoG is achieving some prominence in diagnosing auditory neuropathy desynchrony, but still, for the most part, if somebody's doing electrocochleography in our clinic. It's mostly to help diagnose, assess, and monitor Meniere's disease or endolymphatic hydrops. And this is continues to be the primary application for ECoG, and certainly comprises the majority of electrocochleograms that I do are for this purpose. A little bit about Meniere's disease. It's the idiopathic syndrome of endolymphatic hydrops, described by Prosper Meniere in 1862. Almost a couple hundred years later, we still don't know what causes it. We still don't have a cure for it. We're not sure what the pathophysiology really is, et cetera, et cetera, et cetera. But it continues to be a problem, and it oftentimes presents a diagnostic challenge to identify this disorder. The classic symptoms, of course, include oral fullness and pressure, tinnitus, dizziness, fluctuating hearing loss. So, I mean, if you look at those are all the symptoms that the inner ear gives when there's something wrong with it, and it doesn't have to be hydrops. So what hydrops is, obviously, is something very different from many other things: hearing loss due to noise exposure, acoustic tumor, et cetera, ototoxicity, and not that those other disorders couldn't be accompanied by endolymphatic hydrops. Very quickly, anatomy lesson 101 for the day is if we look at the fluid of the scala media that bathes the organ of Corti, we know that endolymph is produced by the stria vascularis. That's the faucet of the sink. That fluid then flows through the entire endolymphatic system, including the cochlear duct and into the vestibule, into the vestibular system, and then is absorbed into the bloodstream via the endolymphatic sac, which represents the so-called drain of the system. Here are representative drawings showing what a normal ear looks like and one that is characteristic of endolymphatic hydrops. Patients who have this disorder, when they're a little confused as to what's going on, my general spiel when they come in and they ask me about it is there may be other factors going on, but it's pretty well accepted that endolymphatic hydrops is kind of the basis for Meniere's disease in most circles. And if we don't know what the cause of endolymphatic hydrops is, and sometimes there is a cause, then it's called Meniere's disease. But I tell folks that the inner ear is kind of like a sink filled with fluid, that there's a faucet putting the fluid in, that there's a drain draining it out. Sometimes, and theoretically, the amount of fluid going in and being drained out should keep the fluid at a constant or the sink at a constant level. But with Meniere's disease, we're not sure if the faucet's on too strong and or the drain is clogged, either one of which would cause too much fluid to build up, putting pressure then on the stereocilia of the organ of Corti, and certainly altering the transduction process when it does that. We're not really sure what causes hydrops. There could be myriad causes. It could be genetic, allergic, other sort of things going on, and certainly a ton of things that could possibly be related to endolymphatic hydrops. But as we look at the epidemiology, it's somewhat inconsistent. A lot of people don't come in for help until they get dizzy. But it's been estimated that perhaps at least 2% of the population reports symptoms consistent with Meniere's disease, and anywhere from 45 to 100,000 new cases in the U.S. alone. And one of the reasons I got interested in doing electrocochleography is that, it seemed to me that if Meniere's had this much prevalence, and we were doing evoked potentials at the time, way back when, looking for the elusive acoustic tumor, we'd have a whole lot more application for our evoked potential unit than just doing ABRs, and indeed that is the case. I still think that most audiologists with evoked potential units do primarily ABR and not much else, whether that's ABR for diagnostic purposes in adults, which is not all that common anymore, but certainly for newborn hearing screening and things of that nature. Epidemiology of Meniere's, median onset is roughly around 50 years of age, slightly more female than male, and most of the time, at least, it begins as a unilateral disorder. The treatment ranges anything from medical to surgical to vestibular rehabilitation. Some of these work very well. Not all of them work on all people, and some of them don't work for anybody. There's dietary factors going on. There's perhaps an allergic factor going on. I had a physician once who told his patients with Meniere's, do not eat any foods that begin with the letter P, and that included things like pretzels, peanuts, pizza, pepperoni, popcorn, jokingly because they contain a whole lot of salt. So peas are okay, but just don't put salt on it. So again, nicotine possibly, et cetera, et cetera. It's really hard to pinpoint it, and the treatment again can range from a medical treatment, and I didn't have here lifestyle changes, don't eat this, don't drink that, control your cholesterol, what have you, to when it gets bad enough, and usually it's the dizziness that precipitates this, perhaps an endolymphatic subarachnoid shunt, or decompression, or even an eighth nerve section. And you'll find reports in the literature where any one of these has been effective, but certainly not the standard choice of treatment for all Meniere's patients, because there are also reports that show that the endolymphatic subarachnoid shunt hadn't been effective, or the compression wasn't, or people still have concerns even after the nerve has been sectioned. So that's not necessarily the focus of what we want to do today. Today we want to use a test that helps diagnose it so that whatever treatment is decided or management is decided, at least there's an objective basis for approaching the disorder that way, and a way for perhaps monitoring the effects of that treatment or approach in so doing. So oftentimes it's the case that Meniere's, the diagnosis is based on symptoms, but the symptoms can be really highly variable. The four classic symptoms are not necessarily always present at the same time, and if they are, they can be confused with other conditions. And so this emphasizes the need for a more objective test to assess whether or not this is indeed endolymphatic hydrops and or Meniere's disease if we don't know what the cause of that hydrops is. Okay? However, when we do an objective test, it has to be valid, meaning it measures what it's supposed to measure. It has to be reliable. That is, we can get the same results if we repeat it. And very importantly, it has to really correctly identify those who have the condition from those who do not have the condition. So we have to make sure that these tests are both sensitive and specific. For years, really almost for 30 years now, the hallmark of a positive electrocochleogram for endolymphatic hydrops was the observance of an enlarged summating potential component, especially in comparison to the action potential component, and or what we refer to now as the SP-AP amplitude ratio. If that was enlarged, then it was considered, this electrocochleogram would be considered positive for endolymphatic hydrops, especially in comparison to this patient's other ear, which shows a normal ratio. And we'll get eventually to what's normal, what isn't in a bit. The rationale for this finding has never really been totally explained or even totally accepted, but the simplest description of what happens here is that the summating potential represents a distortion component of the transduction process. If hydrops and the pressure associated with hydrops on the cochlear partition and the organ of chordia in particular is present, then that will enhance the distortion aspect of that, again, transduction process. So if we get more distortion in the transduction process, a reflection of that additional distortion is in the form of an enlarged summating potential component. There certainly may be other factors at play here, but that's the general, relatively accepted rationale for why we see a big SP-AP. And I must tell you, as I said, I've been doing these for 30 years. It is a real phenomenon. We do definitely see enlarged SP component. Whether or not it's due to an increased distortion, it could be due to increased pressure, it could be a biochemical reaction, it could be a vascular sort of thing, not sure. But in a significant number of patients suspected of having endolymphatic hydrops, that finding is present and it's real. These are examples of a study we did back in the really early 1990s where we compared tympanic membrane responses to responses taken transtympanically with the needle on the promontory. And I did this in conjunction with some physician colleagues here in Kansas City. And this is the same patient. And what you see here is a very nice, stable, repeatable response. Okay? And here's the summating potential, and here's the AP. And as you can see, the SP-AP amplitude ratio, which in a normal ear should be anywhere from about 10 to 35%, is almost 100%. It's almost a one-to-one reflection of amplitude of SP to AP here, and that's certainly enlarged. Here's a TM response, which is noisier and not quite as repeatable, especially on either side of the electrocochleogram. But if we look at the amplitude of the SP compared to the AP, it's clearly a positive response for hydrops. The other thing you need to point out is obviously, since we're sitting on the promontory, the magnitude of the response is about 4 times bigger from the promontory than it is from the tympanic membrane. To a certain degree, this is why God created the signal averager. You simply take more responses. But the important thing here is that the diagnostic feature of the electrocochleogram, or the feature that leads to the diagnosis of, or the interpretation of electrocochleogram, certainly is preserved at the tympanic membrane, and we found this to be the case with tone bursts, et cetera, et cetera. And so from our perspective, there really is no need to do transtympanic recordings. Coates way back again in the late 80s or so showed that individuals with Meniere's disease, if we look at the amplitude of the SP versus the AP, they all tend to fall out of that normal area, indicating an enlarged SP component, especially again because it's a more stable way to look at it with respect to the action potential, or AP. One of the advantages of being a college professor is that I can convince students to do studies that I really need to have done and convince them, or at least make them think that it's their own great original idea. We all do that, and I admit it. And one that we did several years ago is we took a look at the specificity and sensitivity of electrocochleography, the way we were doing it, using the SP-AP amplitude ratio. And what we found in this slide shows it, is that, for example, we had 50 patients who had negative electrocochleograms, and these were patients all suspected of having Meniere's disease, hydrops, etc. 50 of them had negative electrocochleograms. Okay. 26, almost half of them, then did not receive a diagnosis of Meniere's disease, but almost 25, or almost half of them, did get the diagnosis of Meniere's disease despite the fact that the electrocochleogram was negative. On the other hand, we had 53 patients who had positive electrocochleograms, and almost all of them, over 80%, got a positive diagnosis of hydrops, which basically says ECochG is very specific to hydrops, but it's not all that sensitive. And indeed, at that time, using the SP-AP ratio, other studies have shown the sensitivity of ECochG to hydrops ranges anywhere from really roughly 50 to 65% based on the SP-AP amplitude ratio alone. We did other earlier studies that compared the results of an electrocochleogram to the patients, the symptoms the patients had at the time we did the test, because it became very apparent to me when I was doing these things that I saw differences in the responses if a patient reported symptoms while we were doing the test versus those who came in and said, well, I had the symptoms a few weeks ago, I saw my doctor, I got you scheduled to do this 2 weeks ago, but I don't really have any symptoms at all today. And remembering that hydrops in Meniere's is an episodic disorder. And so we started to monitor the various symptoms that patients displayed at the time of the test. And obviously those symptoms include hearing loss, tinnitus, orofolness, vertigo, only one of which we could objectively measure, that being hearing loss. And we define hearing loss as a threshold greater than 25 dB at any frequency. And then we looked at the symptoms and recorded whether or not the electrocochleogram was negative or positive based on that. And I'm going to come back to this slide in a second. And then we performed some fancy statistics and basically found that hearing loss and fullness were the symptoms, when in combination, were the most accurate predictor of a positive electrocochleogram. In fact, based on the patient's symptoms, we could accurately predict what the outcome of an electrocochleogram was practically 92% of the time. Now, some of you may be looking at that and scratching your heads, because this is kind of not what this is supposed to be about. We shouldn't use a patient's symptoms to tell us what the outcome of a test is. We should use the test to tell us what's wrong with the patient. And when I brought this to the attention of my physician colleagues, they were saying, yeah, but this gives us objective evidence. This gives us something that I can use to justify a treatment regimen. It gives me something, almost more importantly, that I can take into court and say, but see, this is why we did it this way. And so regardless of that, it is an important objective tool for monitoring hydrops. And again, back to this slide, every time you see an asterisk, that means hearing loss and fullness were part of the symptoms. And every time hearing loss and fullness were part, whether it was hearing loss and fullness, hearing loss tinnitus fullness, hearing loss fullness, et cetera, the electrocochleogram tended to be positive. So those are kind of key components. I always ask the patients when they come in, tell me about the symptoms you have right now, not the ones you've had in the past. And again, they can vary from none at times, and why would you expect to see a change in the electrocochleogram if there are no symptoms present? The ECoG really we found to be kind of a thermometer, not necessarily a barometer of anything. And for practical purposes, the ear is normal at that time, at least at the level or the sensitivity level we can measure it with our tests. But as the symptoms, hearing loss itself, not very many. Fullness, really not very many. It's when hearing loss and fullness are there together that we tend to see those positive electrocochleograms show up. And so I pose this dilemma sometimes to my students. I say, so suppose you have a patient who comes in and they've been referred to you by a physician because they're suspected of having hydrops, but when they come in, they have absolutely no symptoms. Do you still do the electrocochleogram, and more importantly, I guess, do you still charge them for that? And it used to be we're like, well, no, I wouldn't do it. No, we don't. Now the students, a different breed of students, of course we still do it, and of course we still charge. So they're learning. But my recommendation is, yes, you do it, but you do everything you can to get them back when they are experiencing symptoms. And sometimes that's very problematic. I don't necessarily want to be, last night's a good example. I'm watching Justified on TV, and I don't want a phone call that says, by the way, Dr. Ferraro, can you come into the lab and measure my electrocochleogram? I think I'm getting dizzy. So that's not realistic at times to do that when patients are having symptoms. But we found that is a really good way to use ECoG, is to get them before or during symptoms and not making comparisons, and we see obvious differences when that's the case. That was using the SP-AP amplitude ratio. Now we've taken to including something called the area ratio here. And by the way, let me just quickly go back to show you something. Amplitude ratio is enlarged, but the way we're measuring the area ratio goes from here to here and here to there. And that would be, and we weren't measuring it back then, that would be also an example of how the area is considerably enlarged in these electrocochleograms as well. And I'll show you what I mean by that in a second here. This stems really from the work of Margolis et al. Back in the mid-1990s, where they looked at the difference in electrocochleogram recordings in response to condensation versus rarefaction clicks. I have no idea how they got such good, clean recordings using a single polarity click to hear, because we get a lot of artifact when that happens. But they were able to show that in some cases of Meniere's disease, there was an abnormal latency difference, interlatency difference, between the N1 evoked by condensation versus the N1 evoked by rarefaction clicks. And if this difference was basically bigger than about 0.3 or 0.4 milliseconds, that too is a positive finding for hydrops. If you use an alternating click, that difference is really masked out, and what you see is just the addition of two, for lack of a better term, phase disparate N1s that don't necessarily reflect an enlarged SP-AP amplitude. And so this curve here, although certainly not normal in our laboratory, it wouldn't be, doesn't necessarily represent an enlarged SP. It represents two APs that have been added together that are out of phase or have a latency delay with latency difference with respect to each other. When I read this article, it reminded me of one that I had read much earlier, and it was done in Great Britain by Morrison et al. And what they showed back in really 1980 was that in subjects with Meniere's disease, they often saw what they called a widened SP-AP waveform. They attributed this to an after ringing, if you will, or an increased elasticity of the cochlear partition in response to hydrops, or an after ringing of the cochlear microphonic, which tended to widen the duration of that component. And so if you look at this waveform here, and you come back and look at this waveform here, they look very similar. The fact that the cochlear microphonic produces an after ringing, or the membrane becomes more elastic or looser, if you will, in response to hydrops, has never been verified. But my suspicion is, since they were using alternating clicks, is that they were really looking at what Margolis found, the addition of two phase disparate N1s, which makes the duration of the complex look wider. So based on this, we decided, well, let's look at both amplitude and duration of the component. And at the time, we were using a Nicolay Spirit evoked potential unit. And I negotiated with the engineers at Nicolay to send me a unit that allowed me to place cursors at different points along the waveform, connect two cursors, for example, with an imaginary straight line, and simply measure the area under the curve between the straight line connected by the cursors and the waveform that was visible underneath that straight line. And so we began measuring the so-called SP-AP area as well as the SP-AP amplitude features. I had a student who did an initial study on this where we had 3 groups of subjects: normal subjects, Meniere's patients with enlarged SP-AP amplitude ratios, 20 of those, and then we had suspected Meniere's patients, but their SP-AP amplitude ratios were normal. The way we measured the area is we set a cursor at the onset of the SP, we extended it to where the waveform returned back to our baseline point, which was the onset of the SP, and we called that the area of the SP. Obviously, it includes the AP as well, but for simplistic purposes, we said the area of the SP. It could be the total area, if you like. And then we took the onset of the AP, the onset of N2 of the AP, or the offset of the AP, and said, that's our AP area. And then we measured this area in comparison to that area to form the SP-AP area ratio. That's a normal subject. Here's one from group 3 that they were suspected of having Meniere's disease, but the amplitude ratio in this case is actually normal. The area ratio, however, shows, and because the N1 really never quite comes back up like it does here, it enlarged the area of the entire complex, or the SP component, and when that was compared to the AP area, this ratio was considerably bigger than that one. Here's another example of someone with an enlarged amplitude ratio and an enlarged area ratio. Almost by definition, if your amplitude ratio is enlarged, your area ratio is going to be enlarged, and indeed our statistics showed that to be true. All of the Meniere's patients in group 2 that had enlarged amplitude ratios also had enlarged area ratios. This goes hand in hand. But interestingly enough, almost half of the patients that were suspected of Meniere's disease that had normal amplitude ratios had abnormal area ratios. We've published that a couple of times. This is Anand DeBio is a resident who was working with me at the time, former student, etc. This is the original study we presented on that. And then a few years beyond that, this was actually in 2009 now, I finally had a great PhD student, Murad Al-Momani, who looked at a retrospective review of almost 300 ears that we had tested and performed electrocochleography on for the purposes of helping to diagnose Meniere's disease. And we examined the sensitivity and specificity of our own recording protocol to really get an idea of which component or combination of components were the most sensitive and specific indicators of Meniere's. And what we measured at the time, and all of our electrocochleograms, were all these features: the amplitude of both components, the areas of both components to form the amplitude and area ratios. We looked at N1 latency. We looked at the SP amplitude at 1,000 hertz and 2,000 hertz tone bursts, etc. Standard protocol for doing a Meniere's workup with ECochG. The subjects we compared, we established norms based on what normal ears look like, and then we did a retrospective chart review of close to, I think I said 3, it was actually close to 200 patients, a total of 348 recordings. And these patients were referred for ECoG testing because they were suspected of having Meniere's disease. At the time, these patients had hearing thresholds less than 60 dB. That's an interesting point. One of the things I hate most is when I get a referral from a physician for someone who's had Meniere's for years and their thresholds are well higher or less sensitive than 50 or 60 dB. ECoG is not of much value when the thresholds are that bad because obviously in hearing losses, especially sensorineural ones of that nature, the hair cells are compromised. What I find ECoG to be most useful is in the early stages of the disease when we really don't know what's going on and the patient still has good usable hearing. Yeah. We divided them into two groups, Meniere's and non-Meniere's disease groups, as diagnosed by the physician. And so what we looked at a little differently is we went back and found what the eventual diagnosis of the patient was by the physician, which we oftentimes never know until you make an effort to call yourself and find out. And then we compared that diagnosis to the electrocochleogram in terms of which components were more sensitive and specific to that. And we measured sensitivity and specifically, statistically, in a manner described here. And our results showed that ECoG is certainly sensitive to the pathophysiological changes of Meniere's disease, might not be sensitive to changes for other disorders, which is good. We found that the SP amplitude to broadband click was significant, as was the amplitude ratio. In other words, that was a significant feature of ears with Meniere's disease, but the sensitivity of this finding was still roughly only 65%. When we included the SP-AP area ratio, however, which was significant, our sensitivity improved to 92%. Our specificity remained high at roughly 84%. So what we now do is we include both SP-AP amplitude and or area ratio in determining whether or not an electrocochleogram is positive for Meniere's. And when you do that, we are about as sensitive as most any test can get for helping to diagnose this disorder. I've presented this numerous places, a lot of workshops really around the world to a certain degree. And some evoked potential manufacturers, Interacoustics being one, have adopted or developed software protocols that now allow us to measure area values in addition to amplitude values. The Interacoustics Eclipse, shown here, is certainly one of those. And what I'm going to do in the next few minutes, what's left, is just kind of show you how we do this. Here's just a raw tracing, a normal electrocochleogram using the Eclipse unit. In a minute, I'll show you the little side panel in terms of how we measure this. You're probably familiar with it anyway. What we do is select the point where we believe the SP begins. This is 0 point here, okay? And in our experience, especially in normal ears and even in abnormal ears, since the SP represents the onset of the signal being transduced in the cochlea, it generally starts anywhere from 0.3 to 0.5 milliseconds beyond the onset of that stimulus. It's almost, you can take that to the bank. And, well, where does it start? I don't see the bump. Look at it closely enough, and these obviously are tracings that have been repeated and added together to form this. So there's a lot of repeats drawn on, 2 to 3. And this is a composite waveform showing, again, this little shoulder of a blip, the SP, the AP. And so we initially mark the onset of the SP and set our cursor there. And then we define where that, we call that our baseline amplitude, so to speak. And then we follow that to the next point in the waveform where it returns to baseline, which is there. And we call that the SP. And then we do simply the same thing for the AP, except instead of looking for a baseline comparison, we start where the AP begins, we end where the AP N2 begins, and we call that the AP. And then we make the comparison, and as you can see here, our amplitude ratio is 12%, well within normal, and our area ratio is around 1. Again, well within normal. One more time, recording like this. Here's where the SP begins, here's where it ends, here's where the AP begins, here's where it ends, and we use this little menu that pops up for when you're doing electrocochleography. You click onto this, then you click to the point where the response begins. You click onto that. You click, that indicates where the SP ends. And again, the amplitude difference between this point and this point should be as close to 0 as possible. And then you do the same for the AP, and your results are displayed along the side of the waveform. Here's a patient with hydrops. Again, here's 0 time. It's about 0.3, 0.5 milliseconds. I'm not sure, the response probably didn't really begin there as opposed to there. But if you look at where it starts, the SP, and where it ends, and compare that to where the AP begins and ends again, we see that the SP-EP area ratio is now over 2. The amplitude ratio is considerably big at 1.2. Our normative values for these features, and we've looked at it 3 or 4 different studies. In general, if the area ratio is larger than 2, we consider that abnormal. It's a nice round number. If the amplitude ratio in response to a 90 dB click is greater than 40 to 45%, that we consider abnormal as well. And especially if that difference is more noticeable and considerably larger in comparison to the other ear, if the other ear is the quote-unquote normal ear. So good round thing, that this should be roughly about 25% for amplitude ratio, ranging anywhere from 10 to maybe 40 to 45. This should be roughly 1, ranging anywhere from 0.8, 0.9 to maybe 1.7 or 1.8. Okay. And I think I've left a few minutes for questions, and there's a lot I've left out, but obviously I wanted to get to the special features of the Eclipse for measuring the response, and I think at this point in time, David, I'm happy to answer any questions.
Okay, I'm going to unmute folks, unmute you all, and if anybody would like to ask John some questions, now's the time.